Hello, we are from PBL 12. So here is our case. Mrs. E is a 35-year-old lady who was referred to you during her first pregnancy at 10 weeks gestation. She has underlying type 2 diabetes for the past 7 years. She has been married for the past 5 years and had 2 previous miscarriages in the last 3 years.
So these are the questions that we're gonna discuss today.
First question, what would be the choice of antidiabetic for the patient? There are 3 choices. First, insulin is the gold standard. Second, metformin. If she is already on metformin, she may continue the treatment. Insulin can be initiated when metformin therapy is contraindicated or not acceptable. Hence, metformin can be used until the end of the first trimester, then be switched to insulin. Third, glyburide. Trials show metformin and glyburide are effective antidiabetic and no evidence of harm to fetus has been found. However, the potential long-term adverse effect still remains a concern. Next, why are those 3 choices ideal? First, insulin, it doesn't cross placenta, it will not get to the fetus and it is safe to use during pregnancy. Second, metformin is generally non-teratogenic but it can cross the placenta. Hence, it is advisable to switch to insulin after the first trimester. Second question, what are the effects of pregnancy to the diabetic mother? Pregnancy can increase risk of complications such as diabetic retinopathy in diabetic mothers. How can diabetic retinopathy happen? Vascular changes induced by the elevated levels of estrogen, progesterone, and human placental lactogen may contribute to the progression of retinopathy in pregnancy. Other than that, the physiological changes of pregnancy impose an added stress on an already compromised retinal circulation. Next, preeclampsia. Preeclampsia is a new onset hypertension accompanied by proteinuria or other signs of severe organ dysfunction in the second half of pregnancy. Preeclampsia risk is increased 2 to 4-fold among women with type 1 or type 2 diabetes.
The third question is, what are the effects of maternal diabetes to the child? So glucose can cross the placenta. So when the mother has diabetes, the extra blood glucose passes through the placenta and the baby would have high blood glucose level. And this will cause the baby's pancreas to create more insulin to get rid of the blood glucose. And the extra energy would be stored as fat. And this which could lead to macrosomia or a fat baby. So these babies may have face problems, for example, damage to their shoulders during the birth. And other than that, because of the extra insulin made by the baby's pancreas, the newborns may have very low blood glucose levels at birth and are at higher risk for breathing problems. So babies born with excess insulin would become children who are at risk for obesity and are also at risk for type 2 diabetes when they become adult. These are some of the effects that could happen to the child with maternal diabetes. So the cardiovascular system, respiratory system, and also nervous system of the child could be affected during the pregnancy and also after birth. So our last question is, what would antidiabetic of choice for her after delivery if she wishes to breastfeed? So this is our treatment of choice. So the insulin requirements drop immediately after delivery and the insulin therapy can be continued at the lower dose. So for the metformin, the low dose can be safely used for breastfeeding mother. And that would be all. Thank you.